Hello, Carl. Good morning.
Hey, good morning. Well, good afternoon for us. It's about 3 o'clock actually in the afternoon, but good morning to you and your audience. And thank you for inviting us to participate in this really inaugural, wonderful conference.
Thanks, Carl. We have a great, full room over here. Let me introduce the panel first. We have a great panel here. We have Stefan Rinfrey, Tony Speedy, Farouk Jaffer, Mauricio Cohen, and Jay Kadri as well. So a great panel to help you out with your challenging case.
All right. Yeah. Well, first of all, I have to kind of introduce my team here. Thank you again for inviting us. I am Cal Alswad. I'm from Henry Ford Hospital. To my right here, Dr. Babar Basir. He's actually our CTO CHIP fellow. He's done a great work in hemodynamic support and a complex coronary artery disease. My helper there, Joe Durek, and I have Jamaica Davis, Jeanette Chapa, Pam Williams, and the doctors actually, and we have an anesthesiologist, Dr. Guruswamy, helping us here. So thank you to all of them. I'd like to thank them in your name for helping me put together this case. And we will go ahead and present the case to you. Dr. Babar Basir, going to go ahead and present the case.
So good afternoon, everybody. This is a 62-year-old gentleman who unfortunately had a large myocardial infarction back in 1993 and was treated medically. In 2006, he had an ICD, and starting in the May of 2016, he started developing worsening angina and heart failure symptoms. He was evaluated at that time and found to have significant 3-vessel coronary artery disease and underwent an MPI for viability and ischemia testing. He had a moderate-sized reversible defect that was completely reversible in the inferior wall and partially reversible in the anterior wall. He was seen by 2 different cardiac surgeons and 2 different healthcare systems, and due to his low EF and poor targets, he was denied for surgery. He's on optimal medical therapy, as you can see on your right-hand side of the screen. So he actually was a patient that we brought for revasc partially back in November. If you can go to the next slide, you can see that he had a kind of a prox circumflex lesion that was treated and kind of distally as well with 2 drug-eluting stents. And at that time, we did the procedure with an Impella 5.0 from the right femoral artery because he also had a complex RCA CTO that we did. If you can go to the next slide as well. So you can see on the left-hand side, he had a complete occlusion. We actually, at this time, did antegrade dissection and reentry into both the right PDA as well as the RPL. And as you can see on the right-hand side of the screen, got a tremendous result. And he felt better for some time, but he still continued to have angina. He still had, his heart failure symptoms got somewhat better, but not completely. And as you can see on the next slide, he has a mid to distal LAD CTO. You can see that there's some faint left-to-left collaterals. Actually, the images that he had from 6 months ago had better collateral circulations than the one that you'll see on our initial shots today. So our initial strategy will be wire escalation. We'll use the hybrid algorithm. If that doesn't work, we'll do ADR and potentially a retrograde bailout. Dr. Alswad will take it from here.
All right. So hi, Mauricio, Farouk, and Jay. Jay is my neighbor in Cleveland Clinic, and Tony and Stefan. So what do you guys think? I want to go ahead and show you the pictures, the initial pictures we did here. So do you guys, can you see my screen?
Yes, we do.
Okay. So there is an LAD lesion. There are 2 diagonals. This, I think the territory of those diagonals is definitely viable, although I don't really believe the non-invasive imaging and the LAD territory itself, it's largely viable. And his EF had improved from 15% back then to about 25% now. He still has symptoms. It took us a long time to bring him back because he's from out of state, out of Michigan, and the insurance gave us a little bit of run around. And the patient literally told my practice that he's feeling so bad, still kind of feeling bad, he wanted to jump off a bridge. He lives next to a bridge. So finally we got the insurance to approve his procedure, and we brought him back. So this is, as you notice, this is a patient with a low EF, has a baseline heart failure symptoms. He has a complex disease in LAD, and we're going to basically using 2 guide catheters. In those patients, my approach to kind of protect 2 criteria, proceed with hemodynamic support, and it depends on the size of the hemodynamic support, is dependent on cardiac power output deficit, and actually the size of the patient, and then after we picked the hemodynamic, prep the hemodynamic support, we picked CP for this patient, Impella CP, and to place an Impella CP, it's better to engage your guides first, put the wires, and then go with the Impella CP, because sometimes it interferes with your
that's a great point, Carl. And actually, we're going to have some point before or after the case, Tony Speedy present about CTO with hemodynamic support, so perfect actually setup. But maybe I can ask you a quick question. Did you have a right heart cath? Do you do right heart cath on these patients just to see where they stand when we start? Or?
Yes. So we did not actually start with a right heart cath in this patient, and it literally, because of the logistics, I would like, he's coming from out of state, and logistically we did not have enough time to put a right heart cath in him. But your point is well taken. When you are suspicious of the need of hemodynamic support, you always will advise to put a right heart cath. In fact, the patient we did this morning, we did the right heart cath yesterday in him. He came the day before, and his filling pressure was okay, except his cardiac power output was low a little bit, and his cardiac output index was only 1.57. So we went ahead and actually did him under hemodynamic support too, although his EF was 40%.
Sure.
So your point is well taken.
And I think, here you can decide to use Impella anyway up front, so maybe the need is maybe a little less because you're going to use support anyway, so maybe not. Maybe I can ask Stefan, maybe give us thoughts on this angiogram. So you have this proxial AD. Stefan, any thoughts on how you would tackle that? You agree with Carl's approach?
Yeah, I think I agree with the strategy that's been outlined. I think it's certainly an adequate first case, possibly ADR, but again, for ADR, it's in terms of distal target, it's certainly not the ideal target, although it seems to be a bit larger downstream. You don't have any branches, major branches down there. There may be a diagonal.
Maybe a little diagonal. I didn't really see much. So if you look here, you can't really discern where is the LAD, but in this cranial view, I'm going to just show you the cranial view here. So this is contralateral injection first, as you all do. You do first inject contralateral, then you inject antegrade to see your distal target. We really have faint, non-visible ipsilateral collaterals filling that LAD more than contralateral collaterals. And after I opened the RCA, I was hoping that there are some collaterals going to come from the PDA, but to our disappointment, there was none really.
They're mostly from an RV branch. What I see to the the apical PDA, maybe going a bit of the LED at the mustache level, right?
I didn't see him really well, Stefan. I think they might be from a diagonal or septal to septal. I honestly, I didn't think if I took.
That's very difficult, huh?
I took an RCA picture only. I think I did, and we did take an RCA picture, and I didn't see any hint of the LED. This is RCA only picture.
So I think, Carl, maybe at the very end, at the very distal LED, you have some feeling. But I agree with you, it's not the best. And actually, personally, I do get, it makes me always more concerned when there's not much feeling, because it's harder. It's going to be harder. If you go subminimal, it's hard to re-enter. But I mean, it's what it is. We know the LED is there. We know it's viable. So
But I think if you look, Cal, it's difficult because of those wires, the ICD wires. If you look at the tip of one of those first ICD wire next to the PDA, there's probably something that lights up. That's the apical LED in the other view. So it might be at some point worth exploring. Not mean going if it's epicardial, but if it's septal, there might be some septal connection there to the apical LED, because there doesn't seem to be any other CTO in that LED afterwards. So I would certainly consider that as a potential option.
Absolutely, and I think that there are several strategies in our head. First of all, I think those diagonals are important. There is lesions before them. The LED is actually disease all the way to the ostium. So the complexity of the lesion is not only in the CTO, and I can see reconstitution. There are probably, I could tell where is the proximal cap. The targets are really poor. There are non-interventional collaterals, and the occlusion length, my suspicion is less than 20. So according to the hybrid algorithm, my approach is basically trying as much as I can integrate. So how about the bailout strategy? I want to kind of pull if I couldn't integrate, and the targets are poor, so I couldn't do it, integrate wire escalation or even integrate the sectional reentry, let's assume. So what's you guys' bailout strategy? I'm trying to decide, should I try those epicardial collaterals? Should I try to go, as you know, the visibility of the collaterals, actually Stefan showed that. It's not that important as much as basically the tortuosity, and we can still cross non-visible collaterals. But I haven't seen any single septal to septal collaterals. I still could try it. What's kind of bailout strategies you guys have in mind for this kind of situation?
So maybe Tony, any thoughts on that?
Yeah, I think I'd probably at least try testing some of them, see if you can get through, just like you mentioned, and if you can't. This vessel is very diseased distally. I don't know if you could still use possibly a star at the end if you and prep it for the future if you don't get a great. But I agree with you. I think your cap's fairly well defined. It's not terribly long. There is a fair amount of calcium right there at the CTO, but I'm hopeful you can get it antegrade.
One thing that can sometimes help is...
I agree with you, and it's like, it's my bailout strategy in this. I was kind of always thinking, it's if before I go retrograde in epicardial collaterals, I might try the septals, but retrograde in epicardial collaterals, it's kind of between, should I try them or should I just star and IVUS and see what happens?
Mm-hmm.
What do you guys think?
Sometimes just doing a tip injection through a microcatheter in the PDA helps you to understand if there are any suitable septals to try to interrogate. So that's another thought to help, go in a view that takes the lead out of the way and then do a tip injection.
Okay. Yeah, so like an audio view?
Yeah.
In fact, this is actually a very good thought. How about we do just a regular audio view and see if we can see, just in the RCA, see if we can see anything. So my wire is parked with the microcatheter at the proximal cap.
And maybe, Cal, for the audience, let's just, if I see correctly, you have an 8 French 45 centimeter seeds, right?
Yes.
And then you have 8 French guides.
So I want to show you something. Can you zoom the camera on the groins?
Oh, it's a double stick, the same artery, right?
Yeah. So what happened? So here, actually, we prepped the radial artery and a groin, and we want to put both groins and right radial artery. We did not prep the left radial artery because I found the older I get, the less favorable the left radial to me because of my back. So we thought we're going to put a catheter in the right radial. We're going to put like an AL6 French or 7 French in the RCA from the right radial, and I'm going to go with the integrate guide. If I have to choose which is the bigger guide, I normally put the integrate is the bigger guide because you need a crossboss in it. The devices can go integrate out a lot bigger, and you can now with the availability of trap liners, guidezilla, and a guide liner, and anchoring techniques, you can actually get through retrograde with a 6 French. You don't really have to do 8 French anymore, as we used to say. So basically, it's about half an hour before we come on camera, and I discovered the right radial artery is occluded. Did an ultrasound. It is actually occluded by ultrasound. So what we did, we stuck ultrasound guided and fluoroscopic guided, one stick, then we stuck toward the wire, so we put 2 8 French in the right groin from it. The other option we could have done, and if you look here, this is the 14 French Impella, you still actually can put 6 French diagnostic catheter alongside it, or sometimes 5 French guide catheter alongside it. The problem with it, you violate the diaphragm and you start bleeding. So this is what we did.
So Carl, this is actually it's a great technique. I don't know, maybe ask the panel, how many people do that, double sticks in their arterial? I mean, here you how to do it, but anyone does this like routinely, or any thoughts on that? I guess silence. So maybe it's not a very popular technique, but I think I've heard many people do this, and it's not. It actually works pretty well. The question is, how do you close it? Do you put like 2 angioseals or pre-close it? That's going to be the issue down the line. But maybe manual pressure just to be on the safe side for this. Shouldn't have the interaction between the closure devices there. But I think it's a brilliant solution. The other way would be to do a snuff box. I don't know if you do the left radial snuff box going from there, but the 7 French might be a little big. Maybe you cut back to 6 French.
Yes, exactly. And you can do ulnar stick if you want, as our radiologist colleagues taught us.
Sure.
However, I did not want to start sticking ulnar. I did it previously about 1 or 2 times. I did not want to do it in a live case.
Sure, perfect. And then one more question. You have a JR4, I noticed, which is very uncommon for the right. Was it hard to engage, or any thoughts about the JR?
No, not at all. This is basically, I was going to put an AL1, but from the radial, because from the radial, JR4 does not give you any support. And so when we went through the groin, I went 8 French and I put a JR4 8 French, and I actually have to wire the RCA. There is a stent actually in the proximal RCA. It's stented from the previous CTO all the way to the ostium. I did not want to basically damage my stent with an AL1 guide, 8 French guide. If I go from the groin, so I said 8 French, and I can anchor, always I can anchor. I have a stent, and I can provide enough support for the GR4, and especially, I am not really expecting that to be successful retrograde in this, although
Sure.
I could be wrong.
Carl, just maybe one question about the access side is, given that this looks in general reasonably favorable for antegrade, could you have started with, if the left radial is accessible, could you have started with a single 8 in the groin, a 6 really just for retrograde backup filling, and then decide if you want to really kind of, go to a second groin access?
Absolutely. The thing about it, after you give heparin, when you sticking the patient after you give heparin, sometimes it's a little bit less favorable. So I normally will get an arterial access and put a 4 French sheath and not put a guide before I give the heparin. I always do that if I didn't want to put 2 guide catheters. But Farouk, your point is well taken.
Is Stefan going to?
Yeah, I think an option, given the environment, the economic environment is very different in Canada, and the reimbursement for Impella is very different as well. In that case, I would have probably gone with two guys and not an Impella to start if the procedure remains an antegrade procedure only. And if it turns out that I would need to instrument the notory artery, then I would have considered the Impella. That's our reality, because so it would have been sort of a bailout as Impella if I cannot cross antegrade, because I think I would say in most of the centers in Canada, this case would be done without an Impella, and I would say in Europe as well. And unless you need to instrument the notory artery. So I think you guys in the U.S. are fortunate to work in such a, it's a belt and suspenders right now, which we usually only have the belt.
Yeah,
Great.
This patient is pretty sick, so I feel safe, and that using hemodynamic support not without its own complications. You have to remember, we end up actually having, according to the NCDR, we have higher percentage of bleeding and groin complications and blood transfusion, but from our experience, rushing to emergency for a hemodynamic support normally doesn't work that good.
No, you're right. You're right. But you could probably do it more electively if you attempt antegrade and you cross antegrade. I would say, in my perspective, maybe the support was not that needed. If you then encounter a situation where you cannot cross antegrade, then you will gear up, then you will get retrograde, then you increase your risk, and then you may want to consider putting your. But I agree with you that then you have to do all of this on heparin, and that's different. So I would have probably put Axis, but not the Impella to start. That's the only difference, because I work in a different environment. But I would say that the Europe would probably be doing the same as well.
And actually, Carl has a nice paper from the study published on this from Progress that I think he makes a good point that kind of semi-emergent is an issue, but I agree with you, if you have the access ready and you're good to go, that can be done in a very short period of time. So, Carl, I know you want to delay. You want to tell us what you're planning. You have a microcatheter up there. What is that, and what's your plan for wire escalation?
So my microcatheter is a turnpike spiral. And I actually, to put the Impella, after I put the guides in, you have to anchor your guides. So I put a 4-water wire in the circ, and it just went in the circ. I'm intending in going integrated wire escalation first, so I went with a workhorse wire. I use any wire I use in here. It's run-through wire. It did not really go well. It kept going into the first diagonal. And then, so I exchanged to the Fielder FC, which is better tip control than the run-through. And I was able to get basically to the second diagonal, and now we're going to get to the proximal cap. After that, I'm probably going to probe it with the Fielder FC because I have it there already. But my natural step, if I got with a workhorse wire there, to use an XTA. It's an Asahi made wire. It's a 0.010 tip and 1 gram tip XTA. The XTR is actually 0.7 gram tip. I've been trialing it, the R for retrograde and integrate, but it does not have enough support. But the XTA seems to be good. My other choice will be also a fighter. It's a Boston Scientific wire, or good old XT. Then I will upgrade from there. If I didn't go to Pilot 200, I know where the proximal cap here, so depend on the resistance I meet. If I need to puncture the proximal cap, I will go right away to Confianza Pro 12 or Gaia 3rd.
Perfect. So while we're working, maybe we can check with our panel. Your thoughts about this? I know there are some people who like the newer wires more, the XT, XTR more. Some others prefer to use the older ones. Any thoughts?
That's it.
Yeah, I'll say I think it's a great plan. I love the XTA, especially, there's a big trend to just start with the 200 on, as Bill mentioned yesterday, but I think this is a perfect case to try a tapered jacketed wire because you might have a microchannel, it's short, and you get a little more support with the XTA, and then so just move to the algorithm.
Very short tip like this. What I normally do, I don't try to advance the microcatheter. The Fielder, this turnpike spiral has a little bit stiffer, but what I do, I twist it and it will follow the wire better. The turnpike spiral has a spiral around it, and I want to just get to the proximal cap. I'm basically spinning and I'm pulling in the same time. I wonder if I am in the proximal cap or. Yep, I'm in the proximal cap.
And so Carl, would you just balloon this if it doesn't? Sometimes a small balloon, if it doesn't go, or do you think it will go eventually?
Yeah, absolutely. So I'm going to go to my XTA. I want the audience to see the XTA tip. Can you zoom in my finger here? So basically the shape of the CTO is about 30 degrees, 1 millimeter. And it's very important to kind of not make it big. This is a very good wire control. And you start with it as tapered. It could actually make it through. I'm not sure if it's make it through a soft plaque. If the plaque is soft, there is a calcification there. We can see actually by fluoroscopy. So I could find the soft tissue between the calcium boulders. And you guys close to Boulder there in Denver.
Perfect. And then Mauricio, there's a lot of calcium over there. Would you think would be an issue for him crossing, or need to change something else. Culture always makes me a little nervous crossing because it can fool you. You may think you're in the you're going around the vessel, but you may be outside or inside. So I don't know any thoughts on tackling that up front, or just get the wire through first and see how it goes, I guess.
So the difficulty here, I really don't have good visualization distally. So if you notice, the wire
looks like you've crossed, right?
I'm not sure yet. I still my feeling, my tactile feet, I still have a lot of resistance against my finger.
But if a soft wire like this one advances straight without knuckling, the probability to be subintimal is extremely low. You're doing very gentle movement, lots of drilling, let the wire go. That's a beautiful technique. And I think you're probably entering that diagonal right now.
You want to take a little picture there, since?
Yeah, we can take an ipsilateral picture.
Nice.
Let me ask you this, before we take a picture, would anybody advance the microcatheter a little bit and then pull it back to see if you have antegrade? Because we have not really dissected yet, right?
That's an option, I think, here. Yeah, I would be okay with it. But I think we'd first start with the contralateral. I don't know other people would do, but I would
do contralateral? Let's do contralateral.
I think, yeah, because if you're in the true lumen, then you're...
I'm not sure we're going to see it, Stefan, but let's try it.
But, the other option, Carl, might be to just redirect the wire. I think Stefan was saying it's probably diagonal. Maybe pull it back and get it down to the LAD, because the distal LAD was feeling in the past from the distal right. So if we can get it down a little bit, you might actually be able to see a little better that it's in the right spot there. Now, of course, if we're subminimal, we take it all the way down. That means we're dissecting all the way down. But again, I think the chance of being subminimal is on the low end of the spectrum right now. Although these bends are a little interesting, I must say.
Yeah, this bend is a little interesting, right? So I'm gonna just give it a little bit of time and see.
Or maybe a picture now is maybe okay after all.
But you're taking the same branches over, so it's unlikely to be subintimal, I would say.
Do you think this is a diagonal or a bend
Sure.
LAD?
I think it's diagonal.
You could do a right shot. You'll see it right away if it's your if you're.
Let's do it. All right, inject.
You see your PDA and the LED is right there. So you're in the
diagonal.
That's the diagonal.
Yeah. And actually, the LED is very large. Do you see it, guys?
Yeah, it's growing.
Okay.
I think what's happening is you lost some
Way back
undergrade
there,
flow
too.
since you put the microcatheter there, right? So now you're feeling maybe less undergrade, and the retrograde feeling is a little better, which emphasizes the point, I guess, for the people in the audience that you're going to have dual injection no matter what. It makes it safer. You may lose your collaterals, the ipsilateral collaterals during the crossing. You're going to have the contralateral in place to guide you when you're going, and that's one of the things why dual access is important.
So this is the technique how to advance the microcatheter. This catheter has a spiral around it. So basically, it spirals around. The spiral basically screws it in as you twisted it clockwise. I would not over twist. So I think I might need actually more tip to get into the ongoing LAD.
At this point, I
you
would
might be good
maybe change the type of wire, get a cyan blue, or get something else with a bit of a different shape, because I think probably your tip curve is too small.
You're right.
Yeah, that's another good point. So Assis was saying twin pass is another option, but I think you're right. A workhorse is probably easier. Now, Carl, would you ever put a little injection there, see if you're good?
With the microcatheter?
Yeah.
No way. Is that a trick question? Are you trying to trick me with something stupid?
I think some of the audience was trying to ask that question, so I asked it for them. So I'll take the heat. But I guess what Carl's saying, is one of the no-nos to do, because if you're true lumen, great. But if you're false and you inject there, obviously you're going to dissect more and you convert it to make it much harder. So unlike periphery, where people do that, you go across, then put your microcatheter there, and then inject. Here you're going to make sure that you're okay first before you inject. Carl, are you still with the same wire? Is it still the XTA you have, or you switched for a...
Still XTA. I think I like this direction of the wire. What do you guys think?
Yes.
I think it's better.
I think it looks good, but I must say I would rather have a soft wire going on just in case. But I think it looks like you're moving without resistance, right? No knuckling, no buckling of your tip. Links are going very smooth.
Nothing. Should we take another picture, guys?
Yes.
Sure.
Yes.
Okay, let's take another picture. Let's do it.
Yeah, that's it, man.
Are we in?
Oh, yes, you
You're
are.
in.
All right, strong work, Al.
You know what?
What are we going to do? What are we going to do in the next hour and a half?
So,
You guys like wait, we still have the diagonal, we have this.
and that was very well done, but I think it's, when I teach the fellows, once we cross with the XT, an XT will never dissect if you don't drill it. If you drill it, then you may be able to get subintimal. But if you just slide once you think you're in, and you just push the wire and the wire doesn't buckle but stays straight, you're sure you're in true lumen. There's no way you can push a wire without torquing that wire and it would not knuckle itself if it's subintimal, for sure. So that's an easy way to confirm with your XT that you're true lumen, is stop drilling it. Just push, just slide. And if it advances straight, you're in. That's what people do is that they keep drilling. That doesn't preclude to be subintimal, because if you drill really fast, you can still keep in a dissection plane.
Perfect. And now see the wire is moving a little bit too far. There you go.
Okay, good. So I'm going to switch to Xi'an blue. Can you guys give me Xi'an blue?
Perfect. So Carl, what's your plan here? It's very calcified. Now you get the wire through. What's your plan next? Are you going to modify? Are you going to balloon? What is your plan for modifying the plaque?
So I was thinking of some modification. We have both access to CSI and rotablation, and I was thinking rotablation in here because we really don't have a big lumen to drill. I just want to kind of modify the plaque and a little bit, and I actually have done rotablation and a CSI in the same lesion, especially osteal lesions or proximal lesion, where I discovered, like, even after rotablation, I still did not have enough expansion of the stent. So basically what I do when I advance a wire, I actually pull my microcatheter back a little bit because it's dug in something. I just don't want to, this is a Xi'an blue.
So it looks like very nicely moving down.
Okay, that's it.
Perfect.
I think we're in, right?
Yes. I think we'll agree. You're perfect.
Yep.
Anybody? So I would, before I put a wire in diagonals, I'm going to actually just go ahead and rotablate this lesion, and then we can actually move. So we have the trapper. So I'm going to need support rotablation, guys.
And maybe Carl can talk in the panel. How many people in the panel would just balloon this first with a 2O balloon or a small balloon first before you rotablation? Just curiosity of what people's thoughts are. So who's for balloon?
I'd be for balloon.
So I think everyone is for balloon first, but
yeah, I might balloon and then image. I might do IVUS just to see how much calcium there really is. If it's circumferential.
Here it doesn't look that calcified. Maybe we're fooled by the transmission, but we.
Look at that, guys. I took a cine, okay? If you see what I'm seeing, I'm not sure if you're seeing what I'm seeing, guys, but there is a shelf of calcium right around that.
Yeah, no, I think it may not transmit as well as you see it over there. I mean, we definitely see there's some calcium moving over there.
Well, it looks like deep calcium. It doesn't look like superficial calcium. I don't know if you're going to ablate anything is going to change your compliance with the plaque. You don't lose that much by going with a small balloon, inflate. I call that palpate the plaque. And if your palpation is like it inflates at 12 atmosphere with a 2O balloon, you know you're not going to do much with your
Or the
rotor.
poor man's IVUS, right? I mean, you take a 2O long balloon, if there's no dents, you've done your IVUS also, right?
Yeah. But Carl, you do what you think is best. I think there's no right or wrong way to skin the cat, right? There are many different approaches over there.
Absolutely.
You may do balloon and then end up having an expanded stent, having other issues. So, there's plus and minuses on both sides. So obviously you can see closer there what is going on the angiogram and decide. The one thing I was going to say is, now we're fairly convinced you're in the true lumen, but in most cases, it's good to do an orthogonal view to make sure that the wire is really in the true lumen versus being in a side branch or something like that. I think your case is perfectly fine, but just for the audience, it's always nice to confirm in both projections.
I'm going to confirm on this projection. How about that? Retrograde.
And I think in your case, you could even take an undergrade injection after you remove the microcatheter because you're true to true essentially. So
exactly. Yeah, we do that on occasion. So the distal,
yeah, this looks awesome.
So Yeah, we are in true lumen. However, we got fooled. We are in a septal. So I'm going to just try to get back into the distal. If you can notice, the distal LAD is significantly diseased. And however, just for the audience, don't be fooled by small size vessel distal to chronically occluded. It is distal, like there is negative remodeling phenomenon, and basically you never know until sometimes 3 months after you open the CTO what is going on in those patients, the actual size of the vessel.
Absolutely, Carl. And now you're removing. Are you clocking, or are you trying to go further down, or are you trying to remove it, or?
I'm actually clocking to go further down, so we can put. I wanna rotablade this.
Oh, okay.
Just I want a 1.5 millimeter burr. Can you guys set up the rotablation? Good. So 1.5 millimeter burr to basically.
Great. So maybe check with the audience. What size burr do you usually use in vessels like this? Do you always go with a 1.5, or you go to 1.25 sometimes, 1.7? Any thoughts from our panel?
I think that the 1.25 has a slightly higher risk of entrapment because of the shape of the burr. So I typically would go with a 1.5 just to be on the safer side.
Yeah.
Or a CSI device which burrs in both directions.
I don't stock 125 anymore. I think it's their rice shape, like a versus a bullet shape, and I think it's if you really think that it cannot afford a 1.5 burr, you should probably ask yourself if you should be doing the rota at the end. So
exactly, yeah, I completely agree with Jay and Stefan. And it's like the 1.25 have higher risk of going through the lesion and not coming back, because it's like a bullet shape, while the 1.5 is more like a football shape, and it's not going to go through the lesion until it ablates the lesion. And the difference between the rotablation and the CSI, that the CSI ablates both antegrade and retrograde, while the burr only antegrade, so you shouldn't push on it, shouldn't let it trap distal to it. So what we're going to do, we're going to show you the trapper. This is basically, I'm not sure if you guys have this, but this is a trapper balloon. This is an old-fashioned trapper balloon. Can you guys see it?
Yep, looks great.
So this is basically the balloon in here. This does not go with a wire. This is just a balloon and a hopper tube to inflate the balloon. But the genius thing about this is here. So if you have a 100-centimeter guide, you keep this here, the black one, stops you before you go at 100 centimeter. So if the guide, at 90 centimeters, sorry. If the guide is 100 centimeter and you want more, you can actually slide it down. So we slid it to here, and now you have a longer shaft, so you can trap in 100 centimeter.
So Carl, you have 100 centimeters, I presume. The guides are long.
No, my guides are 90.
Okay, so you put it back out. So
I don't do CTOs with 100 centimeter guides.
Great. So the trapper balloon is what you saw from Carl. So it makes life so much easier for this trapping. In the past, we used to use 3O balloons for 8 friends, but then when you put it in and take it out, it gets deformed. So it's very hard to put it back in. With the trapper, it's lower profile, and then also you can use it many times. It doesn't get deformed, so you can. And it has this stopping mechanism, so you don't go accidentally too far, go into the vessel and cause some dissection there as well. So
I don't have to look under the floor.
It's very, very useful.
And it's like actually the good thing about it, you'll see. I'll show you in a second when we go with the burr. You can actually trap your wire.
Perfect.
And you can go in with the burr and come back. The fellow does not have to be crucified if they pull the wire, and nobody has to kind of suffer during advancing the rota and removing the rota.
Great. And you can actually ask the audience, how many people use trapping for your cases? Any people use the trapping? Okay, it's about half the people are using trapping for their case, so it's becoming more and more prevalent. It used to be very few people. So this is actually not a CTO technique necessarily. It's for any complex intervention. When you really want to make sure things don't move, this is the best way. You really make sure wires stay put. There's no going forward, backwards. Perforation risk goes down. It's a very, very useful technique for any sort of complex intervention.
Yeah, honestly, the trapping, and the good thing about this trapper, you can use it in 6 French. So I even trap now in the regular cases. So, and it makes your life a lot easier. So this is a 325 centimeter wire.
Do you use rotafloppy or the
support?
Support.
Yeah,
What people on the panel do? Do you use the floppy or the? I must say, I always use the floppy. I never use the extra support.
Floppy also.
I only use a floppy as well.
So everyone uses floppy. But
So,
again, there's no right or wrong answer here. So
I used to use the floppy all the time, and when I joined Bill O'Neill here, he taught me how use the support. In his opinion, is better. So yesterday I was talking to the fellow. I said, "Well, Dr. O'Neill taught me to do the support." He said, "No, Dr. O'Neill does not use the support wire. He actually uses floppy." Anyways, so he taught me how to use the support, and then went back to using the floppy. I think my theory, I actually like it. My theory about the support, I want the wire bias because honestly, it cuts better. That's my theory. I could be wrong, but see, guys, it's actually difficult to pull the mic. It's so tight. It's giving me a hard time to pull the spiral out.
and I guess for the people in the audience, you're counterclocking, right? I see you're pulling as well, but you're counterclocking to some extent to make it a kind of unscrew from the coronary, is that right?
Yes, that's what I'm doing.
So that's the one downside, I guess, of the spiral, that if you go too deep, then getting back, it's a little more friction than if you had a regular turnpike or another microcatheter.
Okay,
But
and don't pull because you can actually get the flanges, the wings, you can leave them in the coronary artery.
you know, we don't want that. And then maybe we can check with the panel people's thoughts about when you do not a CTO like this, obviously, but a regular case. Do you wire with a roto wire or just wire with a regular workhorse and then switch for the roto wire? Maybe we can just go down the.
I think it depends. It's very sometimes if you have like a very difficult or angulated lesion, rotowire can be sometimes difficult to use. But if I can use a rotowire right away in let's say a riot, it's calcified, but I think it's going to be easier to cross. I just want to save a step. So
Sure.
I think it depends on the difficulty you plan in wiring the lesion.
Sure.
That's my decision point.
Tony, do you give nicardipine or any vasodilator for this? Or?
Vasodilator? We're pretty liberal with nitro. I'm not sure how much difference it would make, but we do a lot of nitro. I'm a little more. I've had more frustrating experience with the roto floppy wire maybe than Stefan, and so we tend to use a workhorse, first and then switch out. But if it's a straightforward cross, it might work that well too.
Sure.
So now we screwed out of the lesion, so I'm just gonna pull it. Don't have to unscrew it anymore.
Perfect. And then Farouk, do you ever use temporary for the left, I guess, or just for the right? Temporary pacers, I mean, for the.
Yeah, I tend to. I usually just put a pacer in. I don't overstress about it. Every now and then, there's been a rare bradycardia. I know it's optional for the LAD in particular, but I usually would think, especially in a sick heart.
So if you notice, guys, I'm just gonna no more fluoro. I'm just pulling the.
And we're seeing your pressure is gone, right? So you inflated your trapper, so the red pressure is gone, so it's flattened.
Much, actually, not much. Think about this trapper, which is I don't understand. The pressure doesn't go all the way; it dampens. I don't understand this phenomenon.
So it's funny. I sent 2 of them back. I thought they were not working, so I sent 2 of them back. And then the third one, I decided to try the wire. The wire was trapped, so I had the exact same experience as you said. I'm not sure why the pressure comes back, although we're trapping the wire.
Is there a hole? Is there a hole in that device?
It's more flat than actually. I think it does not. I have no idea why. Actually, this is now I notice that almost every time I trap, I still have the pressure and the wire really trapped. Like I'm not going to pull on it, but it's I'm pulling on it actually here, and the wire is really trapped. But there is a pressure. I don't know how to explain that.
Is there a side hole? It's not distal to a side hole.
No, it's actually I don't use side holes in the left vein, Tony.
Yeah.
So regarding the pacer, I wanted to take this one because we're going to throw a little controversy. I used to use pacers, and then I got to Quebec City, and then Gérald Barbeau was there. And I asked for my pacer in the right, and then the nurses looked at me and they said, but because we haven't been using a pacer for 10 years, so I said, whoa, okay, then you feel like the young guy coming in. So I started to do my rota without, and I figured out that actually without a pacer you do a better technique, because as soon as the guy starts to break, it's probably because you have to break yourself too. You got to let the coronary breathe. So it gives you, if you put the pacer, you do a wrong technique. You pace, you ablate too much, you throw too much stuff down the road, and then that's the reason why. So without the pacer, you do better technique, you do slower runs, you let the coronary breathe, and you have less embolization. I became quite convinced of this.
Okay, so now we have the rota. So the trapper changed my rota technique a little bit. So I used to, the trapper is on, so I have the rota wires trapped. So I used to go dynaglide, see the behavior of the wire, then go. So I don't do that anymore because the behavior of the wire is good. But we can platform. You don't really have to have the brake in the back of the wire but I put it out on anyway, on the back of the wire. Do you have the brake, guys? Okay, but the wire is trapped, so we're going to platform. I normally, for some reason, I always like higher speed, 160,000 to 170, depends. If I'm ablating a stent, I go 170 to 180. So we're going to go ahead and basically,
Sure.
This is, I don't see the console, guys. Where is it? Oh, okay, sorry. That's a dynaglide.
And then the one thing is be careful for the towel, right? I've wasted many bursts throwing the towel.
And your gloves.
Yeah. So, Mauricio, what is your speed that you like for your rotablations? Do you have any specific preferences, high, fast, slow for rotation?
Usually,
160?
I'm a simple operator, so I just use 150, 150,000.
I can see. Can you show me? Good. That's good. So we're going to go down.
There was this one study, I think, from CCI, where they did the comparison 220,000 versus like 140,000 in Japan, and it was pretty much the same. But I'm just curious, people in the East used to go huge, very fast speeds. Here, it's a little the other end, so I don't know what's the right answer. I mean, I go 160, 170 personally, but
I think you heat the plaque much more if you get very high speed. That's been shown on bench. The trend is going towards slower speed. I would say most people are, but there's a lot of gestalt into it. I would say it's like I think it's more the technique and how you push the bird and the speed of the bird.
And Jay, how long do you do your runs? Do you do like 10, 20, 30-second runs? What is your?
Well, it depends on the behavior of the burr. I mean, if the burr is bogging down, it takes more time and you have to slow down because that's where the risk of entrapment is. So you have to gauge it by the behavior. Does anybody in the panel use aminophylline for rotablator cases?
I used it yesterday.
Yeah. We use aminophylline a lot.
Yeah, us too. Do you give for the right coronary, right? Or
for right coronary arteries, we use aminophylline.
I must say, we've changed our pattern as well. We used to use temporary pacers until fairly recently, and now we switched to aminophylline, 250 milligrams IV. And for 10 minutes, and then for 8 hours, you're fine. I haven't had any bradycardia since. Mm-hmm. Of course, it takes away the mechanism that Stefan was saying. Then you don't know if you're doing too much. But I do brief runs anyway, 15, 20 seconds anyway. So I don't think it affects me that much.
It gauges yourself that you're throwing too much adenosine down the artery, so you're breaking. So therefore, it's
sure.
And it works. It works.
And we have yes, Sunil.
So I'm trying to advance.
So Cal, I'm sorry, 1 second, just to explain, because the question of what are we trapping. So what was going on? He trapped the wire, so he didn't have to hold the rotablator and fluoro when he's going up. The rotablator wire is fixed. So the atherectomy is going without looking at the fluoro because you're trapped, so the wire cannot go down and cause any problems.
Okay. Yeah, I mean, I guess we would just use one person holding the wire, I guess.
Yeah, you can do one person only, and also the nice thing, you don't use fluoro or X-ray, your wire position is stable.
So I had it trapped, and I left the trapper then in.
And Carl, you take the trapper out now? Is the trapper out?
I'm going to come back and remove it. Why take it out?
Okay.
Take it out. I just leave it in. Can you get? So now I do 3 things every time I rotablate. Okay. So I actually pull on the whole system until I see the burr coming back physically, and it did. And then I jiggle this, and then I do on the Dynaglide. Probably I can see the panel. So basically on the Dynaglide we find, so we're going to go ahead and start our burr technique. Okay, blood pressure is good, hemodynamic is good. We're going to look there. Here we go. So we platform at 160, but it's 140 now.
You can hear the sound because it's changing. Carl, isn't cranial view maybe a little better to see where it's kind of hard to understand the location here?
I completely agree with you. So we did it 20 seconds. I kind of developed like the Pavlov dog. I actually stopped at 20 seconds without even telling me.
So the one thing, sometimes some people like to go very fast. They go back and forth, back and forth, back and forth. I noticed you were kind of a little more cautious going back and forth. Any thoughts? Like, do you go very quickly, you go slowly, or you can check the panel too?
So I use both techniques. I actually, Bill Lombardi and actually Bill O'Neill, they both go, they lean in the lesion like this, and they wait until it ablates. Well, I like actually a little bit pecking, a lot of pecking. The most important thing is not to stop in the middle of the lesion. So you want your artery to continue, and the blood pressure went down a little bit, but our mean pressure is 72, guys. So the systemic pressure, if you notice, do you see my hemodynamics?
Yeah, I think that looks fairly stable there.
Okay, good. If you notice, the mean pressure is 72, 71, and so basically I give them 20 seconds on, 20 seconds off, and a lot of time I ask anesthesia to treat the blood pressure if they do. I'm still learning how to work with anesthesia, so they give so much anesthetic.
So Sunil did a great talk earlier this morning about atherectomy, and he made one of the points there that you want to really go fast for rotablator and go slow for orbital. And I think that's what you're showing us. You go back and forth very quickly here versus slow if you had the orbital atherectomy.
Yeah, with orbital atherectomy, it's 1 millimeter a second. So it's very, very important. If you go, the downside of going fast with orbital atherectomy is big. And each one of us basically learned the hard way. The good thing about the orbital atherectomy, there is training ground, the SFA or the below the knee. So I learned in the orbital atherectomy, you go 1 millimeter a second. That's it.
Yeah.
You can't go faster than that. And if you stop, and if I hear deceleration, I just kind of stop in there until the deceleration goes down. I don't advance anymore. And the good thing, it gives you a little bit of comfort that you know you're going to ablate forward, you're going to ablate backward. So this is a little bit different technique. But if you want to do chip cases, you have to have access to both devices. And I don't think they are interchangeable. Now, what I do the CSI for osteal lesion, for instant endo expansion. I actually did a few cases. Hopefully there's a paper coming out, right, fellow? Okay. and for bifurcation, left main bifurcation, especially osteal circ, I think the orbital atherectomy is very effective in those lesions. The rotablation in these kind of lesions is very, very effective.
Great. And I think, Carl, you're showing some of the very good parts of the technique, which is patience. When you do rotablation, people try to get a little too fast sometimes and try to do a bunch of runs, don't spend too much time in between, give the coronary some time to recover and get the debris flushed away. So I think what you're doing is perfect. Just do a few runs, give it some time, let the debris flush out, and that makes it safer and less likely to embolize and cause ST changes. The other thing I think in your case is that the way it's behaving actually proves that you're actually right putting a atherectomy up front. I mean, you've tried now, 5, 6 passes, and you're still not through.
Yeah.
So that lesion is actually more resistant than I would have predicted, actually, looking at it from here. So that was a great choice. And also for the support, I think the pressure being down to the 80s, I think that also shows that having the support in place, that's also a good thing. Makes you feel a little more comfortable doing these runs.
1:30, 21 seconds. Okay. So as you know, patience is the name of the game here in these things. You have to wait until the pressure recovers. And the good thing, the Impella support, our mean pressure is 68, 68, 69. So basically, you can't rush those things, and you have to take your time doing it. Absolutely, a great comment, Manos.
And maybe we can discuss in the meantime. I know you mentioned your indications for orbital. That's also an evolving topic, so maybe we can check with our panel their thoughts when you use one versus the other. Like a person like for large versus the orbital, because you can go a little further out and modify more, like 3.0, 3.5 vessels. But I'm curious to hear what people like to do and which circumstances they prefer one versus the other.
Well, I think one of the big considerations comes in the cost. There's quite a cost differential between the two devices, so that I'm sure plays a role in most people's decision-making process. But I think that the orbital atherectomy is a lot easier to use. It's a much friendlier wire, and of course it can ablate going forward and backwards, so it has a lot of advantages from a technical standpoint.
Great. Yeah, I mean, you're right. It's easy use, but more expensive. Any other thoughts from?
I'd just say if it's a long calcified lesion, especially in the CTO arena, I still bias toward rotablator. Maybe it's just because we used it a lot longer, but especially in a long area of disease. This may not be a long CTO, but it's a long area of disease, and so I'd be more comfortable maybe with roto here.
I think the other one is when you have a kind of a balloon uncrossable lesion where nothing goes through. Having the forward cutting from the rotablator might work better. There's one actually new orbital with forward cutting as well, but for now the one we have is only on the sides there.
So the other question which I have for the panel, and I think, what do you think about the distal embolization risk? Is it higher with orbital atherectomy or with rotablation? Can you give 0.5 atropine? So I really don't know the exact answer to that, but I did an SFA orbital atherectomy yesterday, so I put a filter every time I do orbital atherectomy, and the filter was ugly after when I got it out. Can you imagine what we're doing? So, but I don't know which is better, which is less, because in the orbital atherectomy we have 2 speeds, and here we have kind of variable speed we can do, and my bias or my kind of impression, and I'm not sure if that's correct or not, the rotablation has less distal embolization, and I'm with Tony in that. When a long lesion, he tends to use, and I'm too. I think that's a good idea to use an rotablation for long lesions. See, the pressure is going a little bit down, but still the mean pressure is the same.
So, Carl, what I do in those cases, when the pressure starts going down, not feeling great, I just take a picture, make sure that we're not, have no issues going on there. I mean, I doubt you do, but just in case, I think many people like, say, every couple, 3 runs, just do a picture just to see what's going on.
Yeah, we have not crossed the occlusion yet, so let's take a picture.
Yeah, I think it's going to be fine, to be honest, but just as a precaution, just in case something has happened there we're not aware of, that might help.
There is really nothing serious, but if you see the calcium, that chunk of calcium, we have not even gone to that.
Yeah.
You can treat that blood pressure, please. So I'm going to wait until anesthesia gives a little bit of medicine and to get the blood pressure. I'll give a neo sometimes that could improve that.
It looks like your flow is much better, so that's something.
Yeah.
Do you use vasodilator in your dilution for your rota?
Yes, there is a vasodilator, and that could be the effect of the vasodilator in the rota wire.
Yeah, sometimes you may want to decrease a bit the drip rate at the tip of your rota. If you can do that, that can sometimes make a little difference. But
or you could even give, obviously now it's a little too late, but you could give a vasodilator so on. I mean, another option here might be just stop the rotablation and just get a balloon and see, now you modified maybe enough the plaque there, it might be all you need.
Yeah, it could be.
1:38, 12 seconds.
So I don't like the blood pressure, so we're going to have to basically, probably we might have to abort the rotablation. Can you give him a little bit of medicine?
How about just knowing what the right heart pressures are? Any chance that we are volume dry here on the Impella?
The Impella is actually doing good. The volume is not that dry.
Are you at P8?
No suction.
What level are you at?
P9 actually.
P9, okay.
Auto. Okay.
So you almost have no pulsatile flow, it looks
And
like.
some pressors, maybe start some
We're going to
levo.
give him some pressors and probably going to get out of here.
Yeah, I think maybe you're ischemic from the burr being in the proximal, maybe removing the burr, disengaging the guide a little bit, make sure that we restore the flow.
You don't have any issue with your diagonal. You recall that there was a diagonal there. Maybe I didn't look, but that may be worth another assessment.
Okay, so what we're going to do, we're going to trap, and we're going to get the rota out.
Oh, it's better.
A lot better.
Your pressure's better now.
Yeah, we give some medicine. Okay, good. Take it out. Okay, pressure is better. Good, good.
So Carl, you're going to check maybe disengage the guide a little bit, just in case you're a little dampening the pressure there?
I did.
Great. But I think for the audience, this is quite, complex cases, complexity gets complexity happen. I mean, you have to be ready for anything happening, this being one of them. But I think so far, Carl, everything you predicted has happened. It was a very hard to cross lesion. The hemodynamic support was important. So actually, the planning worked out very well.
I mean, it's a beautiful demonstration of the value of hemodynamic support because hadn't been done, it would have been certainly a hard event here.
Stefan, do you think you would have needed the hemodynamic support if you used balloons instead of a rotablator?
So that's the whole issue. Here in my environment, in that case, I would have used a balloon, but if I had considered rotablation, I would have put the Impella because of the complication.
I think that's
so the whole issue is I think, rotablation is for the interventional cardiologist. What a table saw is for the carpenter. It's like once you stop fearing about your table saw, you got to cut a finger. So you have to be all the time thinking about rotablation as it's a very useful tool. It's a very useful device, but we got to be ready for any issues. And Cal was ready. He with the Impella and everything, it was clearly a game changer in that case to have an Impella in.
So we wired the second diagonal, and we're going to go with the microcatheter to exchange.
Carl, do you give a drip? Do you have like a dopamine dobutamine or just a little bolus or
Just a little bolus. What did you give? 5 points of epi? 5 mics of epi. Okay, good. Okay, good.
And I guess that would be a setup if things, if the blood pressure, remains low, then a right heart might be helpful here, actually understanding what's going on. It's a complex patient and other things going on. So again, you put back is that the turnpike spiral again?
Yeah, I put the turnpike actually LP.
Okay.
I did not want to struggle with a spiral back in and out. Just give me a samurai workhorse wire. I'm just going to put it down and basically.
And again, I think we discussed before, the basics are the key. You don't want to be doing complex stuff over a roto wire or over a polymer wire or over a Fielder XT or a pilot. You want to remove them and get a soft workhorse wire, less chance of injuring the vessel. So, and the best way to do this is what Cal is doing through microcatheter and then trapping at the very end.
You have to remember how long you wire and how long you microcatheter, so you don't have to fry yourself and your patient and your staff by looking into the floor every time you're pushing your wire. So I actually have mental image of traps.
And then you put a samurai down there.
Perfect. And Cal, you want to give us a little update in terms of contrast, radiation? We're using heparin, I presume?
Yes, we're using heparin. What was the last ACT, guys?
Almost exactly the same.
Okay. So I need So we have a Pro Water, Samurai, and should we wire that at the diagonal? Yeah, let's wire that at the diagonal. No, I want to keep it, the circ. I want to protect the circ. And 308, perfect. So can you give me just a BMW wire, guys? So I'd like to protect all the vessels. After that, I need 20 by 40 millimeter balloons.
Right.
Universal's fine.
So at this point, we can check with our panel. Would you do anything different? Just balloon, stand, weight, make sure the pressure is okay? Anything else? Would you do any complex stuff on the diagonal? Because it was kind of diseased, right?
Who will remove the GR4 guide catheter at this stage?
Yeah, that's a good point. Sometimes you forget about it during the case. Here, you don't need it obviously anymore.
I think it depends. You don't know if you may have a dissection when ballooning. You may lose the visualization distal. Sometimes I would start working on the LED, open up, get antegrade flow, and then at this point would likely remove my
or at least disengage.
right.
Maybe not remove, but disengage, so you have less issues going on. So Carl, you have a wire in the circuit, looks like a diagonal wire and diagonal in the LED right now.
Yes. So I have a wire in the circuit and a wire in the second diagonal. I'm going to wire the first diagonal. And after that, we're going to just balloon and a stent. I want to protect those diagonals because, honestly, like he needs every myocardial cell he can keep.
And Carl, this wire now, what are you planning? What are you?
I'm just the first diagonal. I'm trying to put it in the first diagonal. That's about it. We trapped.
Great. And the patient was okay during this in terms of chest pain? He didn't have any chest pain or other discomfort during the
he's asleep, right?
Yeah, the patient is asleep. He's actually sedated.
Great. So I guess, calcified lesions, CTOs or not, I guess you can see the challenges associated with this, and then the challenges also with the low ejection fraction and the hemodynamic issues. So very common for complex cases.
I use color coding. The BMW is in the first diagonal. The Samurai is in the LED, and the Xi'an is the Xi'an blue is in diagonal second. So what we're going to do, we're going to go with the balloon now.
Carl, do you have a method to prevent the wires from crisscrossing? I usually use the towel method, which is the cheapest one. But you have so many, and then you push balloons and stuff, and then they become crisscross, and then you can't get anything in the coronary.
So what do you do? What do you do for this, Mauricio?
I just use a towel. So, and then when the towel is folded, I know that I'm in one branch. When the towel is open, I know that I'm in the other branch. And obviously the different wire colors help.
It can be especially a problem if you got a guide liner and it braids, and then you got to take it out.
Especially if you have the wire that gets around the shaft of your guide liner, then you hit the back end of your guide liner if you've deep-seated it.
Yeah, and actually I like to do the same thing, and I put the highest wire on the coronary on the top, and then go down, so kind of remember that the top wire is the top on the screen, just to remember exactly what Mauricio was saying as well.
But the towel trick works very well because that prevents the wires from crisscrossing when you advance your equipment.
So the 2.0 balloon is now expanding. That's good. Okay.
And then, Kalim, the next question, we can check our panel. How long stand would you put here? Would you go further down the LED, balloon, take a picture and see? How much would you stand this vessel?
You need to look and see.
I have an IVUS, so I'm going to use the IVUS now. So I actually will try to stand from normal to normal.
That means to the apex.
16. Yeah.
Is there a normal segment in that vessel? Is there a normal segment in that vessel?
Is that expanding proximal to the second bifurcation at this point? I just can't see. I was wondering.
I couldn't see either, but I think it's not expanding that good. So I want to go with the IVUS next and see what's happening, and we'll go from there. So.
Would you go with the shorter balloon if you ordered the other ones to expand it?
Can you guys give us the IVUS? I need a 2.0 by 15 balloon.
So Carl, can we do this? We have a couple of short talks from Stefan and Tony in between.
Sure.
Since now it'll be ballooning, do you mind if we just give one of them for like 5-10 minutes and then get back to you in 10 minutes?
Yeah. Get back to me, guys. Yeah, no problem.
All right, so we can work over when you come back, we see the ultrasound, and then we can discuss a little more. So we'll see you in a few minutes.
Okay.
All right, thanks, Carl. Perfect work so far.